Bismillahirrahmanirrahim. Uh, Now we will start the ninth session of our reproductive unit, and this is about the ovarian neoplasm. So let's get straight into it. So the ovarian neoplasm, the most common adnexal mass in the women more than 55 years of age, okay, can be benign or malignant, arise from superficial epithelium, germ cell, or sex cord stromal tumor. So these are the three types of ovarian neoplasm, that is epithelium, germ cell, or sex cord stromal tumor. Majority of the malignant tumors are epithelial, that is serous cyst adenocarcinoma, that are, and so serous cyst adenocarcinoma among them are most common. So most common ovarian neoplasm are epithelial neoplasm, and among the epithelial neoplasm, the serous cyst adenocarcinoma are the most common ones. They present with adnexal mass, abdominal distension, bowel obstruction, and pleural effusion. Monitor the response of therapy and replace by measuring the CA-125 level. So the two things that I want to highlight, it is not good for screening. Three things that I want to highlight is, firstly, that the woman who is more than 55 years age, that is most probably post-menopausal, right? So in the post-menopausal women, ovaries are not palpable, right? So if there is any palpable mass in the pelvic region, or in the in the pelvic region, if there is any palpable mass in the women, or in the lumbar, it's not lumbar region. So if there is any palpable mass in the area where normally ovaries can be palpated in a premenopausal woman, so in that particular case we must suspect the ovarian neoplasm until proven otherwise. In a postmenopausal woman, the palpable ovaries is never a good sign. Secondly, the CA-125 is the marker which is used for the therapeutic purposes, because it is elevated in like a lot of other conditions as well. But if it is elevated, so we can start a therapy, and we can check the therapeutic response by the altering level of the CA-125 in the body. So this is good for therapeutic. No, it is not. It is good to monitor the therapeutic response or the relapse, but it is not good for the screening purposes. Now, surface epithelial tumors. Most common type of ovarian tumor. Surface tumors clinically present late with vague abdominal symptoms, for example, the pain and abdominal fullness, and signs of compression, for example, the urinary frequency. Prognosis is usually poor for surface epithelial carcinoma. Worst prognosis of female genital tract cancer. So prognosis is generally poor for the surface epithelial cancer, and it is the worst prognosis of the female genital tract cancer. Epithelial carcinoma tend to spread locally, especially into the peritoneum. That is an important one. It can spread to the peritoneum, and risk factors include epithelial cancer. So risk factors of the epithelial cancer ovary are as follows: infertility and nulliparity, endometriosis, mutations in the BRCA1, BRCA2 mutations, and Lynch syndrome. So these two kind of mutations are very important when we talk about the genetic risk factors for the epithelial ovarian cancer, and then the postmenopausal age. So these four things are very important. Protective factors include oral contraceptives, multiparity and breastfeeding, tubal ligation, and salpingo-oophorectomy. Salpingo-oophorectomy means the ovaries along with the fallopian tubes are being removed. Risk increases with advanced age, polycystic ovarian syndrome, and strong family history. If there is strong family history, so then it means that there is a familial predisposition of these genes like BRCA1, BRCA2, or maybe MSH, MLH1 genes in the case of Lynch syndrome. They are derived from the coelomic epithelium that lines the ovary. Coelomic epithelium embryologically produces epithelial lining of the fallopian tube. That is, coelomic epithelium embryologically produces the epithelial lining of the fallopian tube, serous cells, endometrium, and the endocervix, that is mucinous cells. Okay. So the two most common subtypes of surface epithelial cells are serous and mucinous. Both are usually cystic. So the epithelium, listen, when we talk about serous variety of adenocarcinoma, serous variety of ovarian epithelial tumors, so we are talking about fallopian tube like cells. Or if we are talking about mucinous variety, so we are talking about the endocervix or endometrium like cells which can grow on the surface of epithelium. So coelomic epithelium embryologically produces the epithelial lining of the fallopian tube, which is of the serous variety, and endometrium and endocervix, which is mucinous variety. So the two most common subtypes of the surface epithelial cells are serous and mucinous, and then we have also like Brenner tumor and the endometrioid tumor. They are minor or rare varieties. We'll talk them as well. We'll talk about them as well. Both the serous and mucinous are usually cystic. So serous tumors are full of watery fluid, and mucinous tumors are full of mucus-like fluid. Then mucinous and serous tumors can be benign, borderline, or malignant. The benign tumors are called as cyst adenomas. So whatever tumor has oma at the end, that is usually benign. It is composed of a single cyst with simple flat lining. Okay, most commonly arises in the premenopausal women 30 to 40 years of age. Malignant tumors are cyst adenocarcinomas. They are composed of complex cysts with thick and shaggy lines, and most commonly arise in the postmenopausal woman 60 to 70 years of age. What are borderline tumors? They have features in between the benign and malignant tumors, as the name indicates. They are like on the borderline, and they have a better prognosis than clearly malignant cells, but still carry metastatic potential. BRCA1 mutation carriers. BRCA1 carriers have increased risk of serous carcinoma. They have increased risk of serous carcinoma of the ovary and fallopian tube. BRCA1 carriers often elect to have a prophylactic salpingo-oophorectomy along with prophylactic mastectomy due to the increased risk of breast cancer. So the person or the woman who has BRCA1 mutation has increased risk of breast and ovarian cancer. So she can electively choose salpingo-oophorectomy along with a prophylactic mastectomy, even if the carcinoma symptoms are not there still, or they are still undiagnosed. So in that case, we can do the prophylactic salpingo-oophorectomy along with the prophylactic mastectomy. Less common subtypes of the superficial surface epithelial tumors include the endometrioid tumor, that is composed of endometrial-like glands and usually malignant. So these are usually malignant. May arise from the endometriosis. Endometriosis means that the endometrial tissue that is usually present inside the uterus, that may break down from there and get itself lodged into some other place. Suppose that this is uterus, and here we have the cervix and vagina, and this is the fallopian tube, and another fallopian tube, and here we have the ovary, and this is another ovary. So suppose for some unknown reason the endometrium that is lining the ovary, the internal structure of the uterus, that gets dislodged from here, and it enters all the way into the ovary or maybe some other place. There are some theories to that. Endometriosis, we will study that, but some theories are like they can spread because of reverse menstruation. So normally the menstrual blood comes downwards and passes out of the body through vagina. If there is reverse menstruation due to some unknown reasons, so the blood from here may start flowing back into the fallopian tubes, and from the fallopian tubes they can place the endometrial tissue over the ovaries or some other structures. Then there can be lymphatic spread, or then there can be some the pluripotent stem cells are present throughout the pluripotent stem cells are present in the body. The pluripotent stem cells are those cells, like you can call them the stem cells, which can get differentiated into any type of the body cells. So if those body cells, for example in the ovary, because ovary is the site of the development of follicles and all that, so if any cell in the ovary or some other structure gets itself differentiated into the endometrial cells, then that can also lead to the endometriosis. So this was just a brief discussion about endometriosis. Now let's come back to the topic. The endometrioid tumor may arise from endometriosis, which means that if the endometrial tissue from this area, if this get itself lodged all the way into the ovary, so this will cause the endometrioid tumor formation. 15% of the endometrioid carcinoma of the ovary are associated with an independent endometrial carcinoma, that is endometrioid type. So 15% of the endometrioid carcinomas of the ovary are associated with an independent endometrial carcinoma. So they can arise from endometriosis, but 15% of the time when the person is developing the endometrioid carcinoma, so the endometrioid carcinoma is independent of endometrial carcinoma, the endometrial carcinoma is not there, it is happening independently in the ovary. So it is like that. The Brenner tumors, they are kind of benign. So Brenner, they resemble the bladder epithelium. Transitional cell tumors, solid tumors that is pale yellow tan and appears encapsulated. So pale yellow tan, that is on the gross morphology, the solid tumor that is pale yellow tan and appears encapsulated. There will be coffee bean nuclei on H&E stain. If you can see the coffee bean nuclei, I can't see them right now in this picture. Maybe something like a coffee bean is present over here, or maybe this is the coffee bean nucleus, but I don't know. So coffee bean nucleus will be stained on H&E staining, and they are usually benign, and they are structurally similar to the mucinous variety. So sometimes they are referred to be the subtype of the mucinous variety, although they're different. And the most important thing about the Brenner tumor is that there will be nests of transitional epithelial cells. Like suppose that these are the cells, so there will be a nest of cell over here which will resemble the transitional epithelium, then there will be a nest over here and maybe over here. So there will be a nest of transitional epithelial cells in the case of Brenner tumor. Serous cyst adenoma. So what is serous cyst adenoma? The most common ovarian neoplasm lined by the fallopian tube-like epithelium, and we know the fallopian tube-like epithelium is of the serous cells. So coelomic epithelium, that is lining the fallopian tube, that is of the serous variety. Serous cells are lining the fallopian tube, so they are lined by the fallopian tube like epithelium, and they are often bilateral. So serous cyst adenoma are often bilateral. What is mucinous cyst adenoma? They are multiloculated, large, and lined by the mucus secreting epithelium. As you can see, this epithelium which is lining this ovary is filled with mucus. Okay, so you can see that there is a lot of mucinous or eosinophilic mass that is present inside these epithelial lining cells. So these cells are basically multiloculated, large, lined by the mucus secreting epithelium. Then we have serous cyst adenocarcinoma, most common malignant ovarian neoplasm, frequently bilateral, and that contains the samoma bodies. So samoma bodies is a very important finding, and you must remember that it is one of the the mnemonic for the samoma is samoma, and the S of the samoma is for the serous cyst adenocarcinoma, and these are onion-like bodies, and it is very hard to differentiate them from the other ones which were samoma bodies, and the other one were I don't know, the keratin pearls. So they look very similar to each other. So always use the history points written in the question stem to differentiate both of them. So this is something like this one is samoma body. Now coming back to the picture, so cyst adenocarcinoma are characterized by the presence of samoma bodies. Then we have mucinous cyst adenocarcinoma, rare malignant mucinous ovarian epithelial tumor, may be metastatic from the appendiceal or other GI tumors. So mucinous cyst adenocarcinoma may be metastatic from appendiceal or GI tumors. So maybe the mucinous tumors are present somewhere else, like in the appendix or in the GIT, and from there they have metastasized all the way to the ovaries. They can result in a pseudomyxoma peritoni, intraperitoneal accumulation of the mucinous material. This means that the peritoneum that will be filled with the mucus, and that is called as the pseudomyxoma peritoni. Then what are germ cell tumors? Are we done with that? We are kind of done with that. So the basic hallmark finding of these tumors will include pleural effusion, ascites, and yes, and they can metastasize to the body. So the most common site of metastasis is the lungs, so that over there they cause pleural effusion, and they can also seed into the peritoneum, resulting into the ascites. So these two findings are very important for these tumors. Then we'll move forward to the germ cell tumors. Second most common type of ovarian tumor, that is 15% of the cases, will be germ cell tumor. The most common type is the surface epithelial tumors. Now the second most common type is the germ cell tumor. Usually occur in the women of the reproductive age. Tumor subtype mimics the type normally produced by the germ cells. The tumor subtype mimics the tissues which are normally formed by the germ cells. Fetal tissue, that is cystic teratoma or with an embryonal carcinoma. Oocytes will produce dysgerminomas. If it is originating from the yolk sac, it will be called endodermal sinus tumor, and placental tissue, it will be called choriocarcinoma. So these are the four sub-varieties of the germ cell tumor, that is the cystic teratoma or embryonal carcinoma, dysgerminoma, which is originating from the oocyte, endodermal sinus tumor coming from the yolk sac, and the placental choriocarcinoma, which is coming from the placental tissue. What is mature cystic teratoma or dermoid cyst? Cystic mass. So whenever you come across the word teratoma, so you must become vigilant that teratoma will be a tumor that will be containing a lot of different structures of the body, like structures which are derivative of all the three layers, which are ectoderm, mesoderm, and endoderm. So if a tumor is containing structures from all the three layers, it is called as teratoma. So mature cystic teratoma means cystic mass composed of fetal tissue derived from 2 or 3 embryologic layers, for example the skin, hair, bone, cartilage, gut, and thyroid. So it is a germ cell tumor that is originating from the fetal tissue, like this one we are talking about, the first one. So cystic mass composed of the fetal tissue derived from the 2 or 3 embryologic layers like skin, hair, bone, cartilage, gut, and thyroid. Most common ovarian tumor in the females 10 to 30 years of age. Most common ovarian tumors in this age group. Okay, but the overall most common is the surface epithelial tumors. Can present with a pain secondary to the ovarian enlargement or torsion. Benign, but presence of immature tissue, usually the neuroectoderm or somatic malignancy, usually the squamous cell carcinoma of the skin, indicates the malignant potential. If it is mature and if we have mature distinct structures, so like it is a benign condition. But the presence of immature tissue like the neuroectoderm or the somatic malignancy, usually the squamous cell carcinoma of the skin, indicate the malignant potential. Okay, immature teratoma, it is very aggressive, malignant, and contains the fetal tissue, for example the neuroectoderm, commonly diagnosed before age 20. What is struma ovarii? So struma ovarii is basically a condition when the teratoma is composed primarily of the thyroid tissue. As you can see in this picture, these are like thyroid follicles and stuff like that. So these If the teratoma is composed of thyroid tissue, they will give you in the question that there is a ovarian cancer, and when the biopsy was done, so there was a lot of follicles filled with the fluid they were seen. So that is they may also give you a picture like that. So this is stroma ovarii, which is a variety of the cystic teratoma. I guess that is a variety of the mature cystic teratoma, but it is a variety of the teratoma. Remember that. So stroma ovarii is the teratoma composed of primarily the thyroid tissue, and it is also called as monodermal form. So it is coming from only one skin layer, and now you have to see that from where the thyroid is coming. So I don't remember that. Kindly go to the part 1 of the video where we discuss the different germ layers. So it will be definitely mentioned over there. So it is a monodermal form of the teratoma, in which we find the thyroid tissue inside the ovary. Then here you can see a hair follicle. It is kind of tricky to locate them. So it is a hair follicle over here, and then we have epidermis and dermis because of the presence of the stratified squamous epithelium, which is not normally present on the surface epithelium, because the surface epithelium of ovaries is normally cuboidal type. But if we find a stratified squamous kind of epithelium, so that is basically coming from ectodermal remnant, and that is epidermis or dermis. And then we have sebaceous gland. So it is helpful for diagnosis, like sebaceous gland. I didn't know that sebaceous gland looks like that. So sebaceous gland, hair follicles, and the epidermis is present in this picture. Now you can see over here that what is it? I guess it is a teratoma, the whole of it, the ovary containing the teratoma. So there are a lot of different type of structures, and I guess this is a picture from pathoma because these are highlighted stuff, but I don't know what are the things that are highlighted. There is some structure over there, and this is also a structure, and some structure, I guess teeth are over there. Okay, so then dysgerminoma. What is dysgerminoma? Dysgerminoma tumor cells composed of large cells with clear cytoplasm and central nuclei resemble the oocytes, and there will be sheets of uniform fried egg cells. Okay, so just give me a second. Mucinous adenoma, no. Got it. Okay, that is teratoma. Yeah. So if the germ cell tumor is originating in the oocyte, then it is called as dysgerminoma. Okay. So now what is dysgerminoma? Dysgerminoma is originating from the oocyte, and oocyte is basically an egg. So all of these tumors will have a fried egg appearance. That is just a memory tool. It is not a scientific thing or anything. So remember that the sheets of uniform fried egg cells will be there in the case of dysgerminoma. They are originating from the oocyte, like they are the derivative of the oocyte of the ovary. So in that particular case, these cells will contain sheets of uniform fried egg cells. Most common malignant germ cell tumor. Okay, it is the most common malignant germ cell tumor, the most common in adolescents. Okay, then testicular counterpart is the seminoma, which is relatively common germ cell tumor in the males. So the most common malignant germ cell tumor in the female is the dysgerminoma, and it is a counterpart of the seminoma in the males. So you must remember that. So now we have like three counterparts. I'm just revising stuff. So the Leydig cell in the males have a counterpart in the theca cell in the females, and the Sertoli cell in the male have the counterpart of granulosa cells in the female. Now the dysgerminoma have a counterpart. Dysgerminoma is in the females, and the counterpart in the male is called as seminoma. So remember these things. So relatively common germ cell tumor in the males. Good prognosis and response to the radiotherapy. HCG and LDH are the tumor markers. So HCG and LDH are the tumor markers. Okay. Then we have endodermal sinus tumor or the yolk sac tumor. So the tumor is originating from the yolk sac. It is called as the endodermal sinus tumor. Malignant tumor that mimics the yolk sac. Most common germ cell tumor in children, and most common tumor in the male infants. Serum alpha fetoprotein is often elevated. So in the case of endodermal or yolk sac tumor, the serum alpha fetoprotein will be elevated. And in the case of this tumor, like the dysgerminoma, will have an elevated HCG and LDH. So remember these markers, they are very important and they are high yield on the step 1 exam. So endodermal sinus tumor will have an alpha fetoprotein elevation, aggressive in ovaries or testes, and sacrococcygeal area in the young children. So endodermal sinus tumor, the yolk sac tumor, yes, I guess these are the tumors with the in males we will study that, but in the males they are associated with the Schiller-Duval bodies or stuff like that. I guess these are the ones. So they contain alpha fetoprotein is often elevated and aggressive in ovaries or testes and sacrococcygeal area in the young children. Histology: yellow friable hemorrhagic solid masses, and they will be Schiller-Duval bodies, glomerulus-like structures. They're not glomeruli, they don't function like glomeruli, but they look like glomeruli. So that is why they're called as they're named Schiller-Duval bodies. And there will be yellow friable hemorrhagic solid mass. Then here you can see that this is something which I don't know what is that. I guess it is Schiller-Duval body or something. I guess it is Schiller-Duval body, but they have not mentioned it, so let's check it out. What is a Schiller-Duval body? So yes, it is a Schiller-Duval body. So this is the picture of a Schiller-Duval body. I'm sorry. So coming back, it is a Schiller-Duval body. So you can see that the outer rim is maybe looking like or mimicking a Bowman space, and then there is a central tuft of capillary if the glomerulus looks like that. So this is a Schiller-Duval bodies picture, and there are like a lot of Schiller-Duval bodies. So if on histology you find Schiller-Duval bodies, and on top of that they tell you that the patient is having a elevated serum alpha fetoprotein level, so you must go for the endodermal sinus tumor or the yolk sac tumor. Then choriocarcinoma. Choriocarcinoma is a malignant cells composed of trophoblast and syncytial trophoblast. They mimic the placental tissue, but villi are absent. So just to revise, let's come over here. If the germ cell tumor, if they are originating from the fetal tissue, they are teratomas. If they are coming from the oocytes, they are dysgerminomas. From the yolk sac, they are endodermal sinus tumors, and from the placental tissue, they will be called as choriocarcinomas. So choriocarcinoma are the malignant tumors which are composed of trophoblast and syncytial trophoblast, and they mimic the placental tissue, but the villi are absent. Small hemorrhagic tumors with early hematogenous spread. Okay, so we remember that 4 carcinomas root hematogenously, and the C in this mnemonic was for the choriocarcinomas. The other one was follicular carcinoma of thyroid, choriocarcinoma, renal cell carcinoma, and hepatocellular carcinoma. This mnemonic is written in the general pathology section, so when we will do that section, we will come across that. Right now I'm not writing all of that, so remember this one. So choriocarcinoma has an early hematogenous spread. The beta HCG is characteristic because it is produced by the syncytial trophoblast, and if it is a carcinoma of the placenta, which contains cytotrophoblast and syncytial trophoblast, both of the layers, so the beta HCG is characteristic and produced by the syncytial trophoblast. It may lead to the theca cells in the ovaries pardon me, and poor response to the chemotherapy. So the choriocarcinoma, it does not contain villi, it has a hematogenous spread, it has an elevated level of beta HCG. There was another tumor with a beta HCG, and that was this one, dysgerminoma. Yep, dysgerminoma has HCG level elevated, and choriocarcinoma also has an elevated HCG level, and there is a poor prognosis to the chemotherapy. Then moving forward to the embryonal carcinoma, malignant tumor composed of the large primitive cells, and embryonal carcinoma has aggressive with early metastasis. So embryonal carcinoma is malignant tumor composed of the large primitive cells, and it is aggressive and early metastasis can be seen. Now we have sex cord stromal tumors. So just a quick revision of the germ cell tumors. They can be, if they originate from the fetal tissue, they are cystic teratomas or embryonal carcinoma. And for the cystic teratomas, there are a lot of things like immature teratoma will be aggressive, mature teratoma is usually benign, and then stroma ovarii will contain thyroid tissue. Secondly, we have oocyte derivative, that is dysgerminoma. In the case of dysgerminoma, we have, because that is coming from the oocyte, so we will have a fried egg appearance, and then HCG and LDH are the lab markers. For the endodermal sinus or yolk sac tumor, alpha fetoprotein level is elevated, and we will find Schiller-Duval body which looks something like that. And for the choriocarcinoma, the level of beta HCG will be raised like dramatically, and there is a hematogenous spread of the choriocarcinomas, and there is a poor response to the chemotherapy. And for the embryonal carcinoma, they are malignant tumors which are composed of large primitive cells and aggressive with an early metastasis. What is sex cord stromal tumor? So remember, for the sex cord stromal tumor, fibroma is benign. Benign tumor of the fibroblasts. Okay, fibroblasts, they are sex cord stromal tumor. Okay, so the benign tumor of the fibroblast, bundles of spindle shaped fibroblasts will be seen. What is Meigs syndrome? In the case of Meigs syndrome, there is a triad. So a triad of what? There will be a triad of ovarian fibroma. Okay, there will be ovarian fibroma, Then we have ascites, okay, ascites, and then we have hydrothorax. So three things will be seen, that is hydrothorax. What is hydrothorax? I guess it was supposed to be pleural effusion. Hydrothorax. Hydrothorax refers to the presence of pleural effusion in the patient with cirrhosis who does not have other reasons to have pleural effusion. So hydrothorax is basically the presence of pleural effusion in a patient with cirrhosis who does not have other reasons to have pleural effusion. Hepatic hydrothorax occurs, blah blah blah. So basically hydrothorax is a fancy word which is used for the pleural effusion. So in the Meigs syndrome, the person or the woman will be having ovarian fibroma. On top of that, she can have ascites and hydrothorax, and a pulling sensation in the groin can also be felt, because it's a ovarian tumor and it can lead to a pulling tumor. It's benign. Like the tumor itself is not metastatic, that is why it's benign. But benign does not always mean that it is it is not dangerous. To be benign does not mean not dangerous. It can be very dangerous because it is leading to ascites and hydrothorax. On top of that, it is ovarian fibroma, so pulling sensation in the groin will also be felt. So remember these things. Then then we have thecoma. Thecoma is a benign tumor. Like granulosa cell tumors may produce estrogen, usually present as abnormal uterine bleeding in a post-menopausal woman. So thecoma is also benign. It is like the granulosa cell tumor. Okay, we'll come across the granulosa cell tumor later on. So it is like granulosa cell tumor because it can produce estrogen. Thecoma. How so? How come? Because thecoma is a tumor of the theca cells. Like, right? So these are the theca cells, and under them we have the granulosa cells. If there is a thecoma and there is increased androgen production, so that androgen production, if there is an increase in the androgen production, so that androgen is going to enter the cells and enter the granulosa cells, and granulosa cell will be converting them into estrogens. So estrogen level will be high in the body. So the granulosa cell tumors may produce estrogen and usually present with a abnormal bleeding in the post-menopausal woman. Why will there be bleeding? Because whenever there is estrogen, the endometrial tissue starts proliferating, and if that will proliferate, so there will be abnormal uterine bleeding in the post-menopausal women. Then the granulosa tumor is malignant. So let's see that the clinical features of the granulosa cell tumor is that large unilateral adnexal mass, there will be increased estrogen, endometrial hyperplasia and precocious puberty, and increased inhibin. So thick endometrium by unopposed estrogen, or by I don't know what, thick endo by USN Nestor by, okay, so I don't know what that is. Post-menopausal bleeding will be there, like endometrial hyperplasia can result in thick endometrium, post-menopausal bleeding, and breast tenderness can also be seen. And it is not only seen in the post-menopausal women, it can also lead to precocious puberty, the granulosa cell tumors. Histology, there are colexner bodies, like never ever forget this one. For the granulosa cell tumors, the colexner tumors, they will always give you there was a question in the Uworld in which they were telling that there are some tumor, and in that tumor the person is having like cuboidal granulosas, cuboidal cells in a rose shaped pattern, or the rosette pattern of the cuboidal granulosa cells with the coffee bean. They were not giving the coffee bean nucleus, but still they were telling about the cuboidal cells. So you must think of the colexner bodies if they're telling you about precocious puberty or about the postmenopausal bleeding or stuff like that. So that is the granulosa cell tumor of the ovary. Histology, you will find yellow theca cells with lipids, and give granny a call, that is a good mnemonic. Then Sertoli lady cell tumors, they are like male like tumors. Okay, so they compose of Sertoli cells. Sertoli cells are normally present in the males, but in the females we have, like, what are the counterparts? The granulosa cells, which are the counterpart of the Sertoli cells. So here we have the Sertoli lady cell tumors. So composed of Sertoli that form tubules, okay, and the lady cells between the tubules, which are characteristic of the rinky crystal, with characteristic rinky crystal. Okay, so you can see in this picture, this pink thing is a rinky crystal. So it is not about the granulosa cell tumor or stuff like that. It is composed of Sertoli cells which are forming the tubules, and lady cells between the tubules. So they are characteristic with a characteristic rinky crystal. Okay, so you can differentiate between the granulosa and the Sertoli lady tumor in a way that the granulosa tumors they will be forming the colexner bodies, and for the Sertoli lady tumors they will be forming the Sertoli cells from the tubules and the lady cells between the tubules. They may produce androgen associated with the hirsutism and virilization. Ovarian sex tumors. The first one is the granulosa theca tumor, then certainly lady and the fibroma. So we are talking about the ovarian sex core tumor. Before that, we talked about the germ cell tumors. What was the germ cell tumor? The teratoma, and then it was the yolk sac tumor, the endodermal sinus tumor, or the yolk sac tumor. Then choriocarcinoma was there, and then we had like choriocarcinoma. There was one more choriocarcinoma and no dysgeminoma. So these were the things, and then we also had embryonal carcinoma. Now talking about the sex core tumors or the ovarian sex core tumors, we have granulosa theca tumor, and then there is sertoli tumor and also the fibroma. So granulosa theca tumor presentation is hyperestrogenism, endometrial hyperplasia, and precocious puberty. And we will find the call-axonal body which is cell in the rosette pattern, cuboidal cells in the rosette pattern, and cuboidal granulosa cells in sheets or codes, yellow theca cells. So call-axonal bodies are the cells in a rosette pattern, and cuboidal granulosa cell in sheets or codes or the yellow theca cells. Then certainly Leydig tumor, hyperandrogenism, amenorrhea, hirsutism. So in the case of certainly Leydig tumor, the female will develop virilization. So what is meant by that? There will be hyperandrogenism, amenorrhea, hirsutism, deepening of the voice, male pattern baldness, and acne and clitomegaly. Let me clear that. So remember these things. Along with that, pink certainly cells with the tubules or codes same as testes can also be seen. In the case of fibroma, the female can develop Meigs syndrome, that is ovarian mass with ascites and pleural effusion, and there are also yellow theca cells. So yellow theca cells can be found in the granulosa tumor or maybe in the fibroma. So remember the pet points about them. So in the case of granulosa, there can be call-axonal bodies. In the case of certainly, there can be rinky crystals, and for the fibroma, we are having the Meigs syndrome with ovarian mass and ascites and pleural effusion. Metastatic tumor to the ovary, that is important one, that sometimes the tumor is not primarily originating inside the kidney. There can also be secondary tumor, that is, it is metastasizing from some distant side. For example, the Krukenberg tumor. The metastatic mucinous tumor that involves both ovaries. So firstly it is metastatic, secondly it is mucinous, and thirdly it is involving both the ovaries. Bilaterality helps distinguish the metastasis from the primary mucinous carcinoma of the ovary, which is usually unilateral. That is very important. If the mucinous tumor is unilateral, it is the primary mucinous tumor of the ovary, right? And that is surface epithelial tumor. And if there is mucinous tumor which is involving both the kidneys, then you must keep the Krukenberg tumor high on your diagnosis, and you must screen the GIT for any tumor over there. Most commonly due to the metastatic gastric carcinoma of the diffuse type, which contain the signet ring cells, like signet ring cells, and those signet ring cells will now enter the ovary, and they can also be seen on the morphology. Then we have the pseudotumor cerebri. So it's pseudomyxoma peritoni. Massive amount of the mucus in the peritoneum due to the mucinous tumor of the appendix, and may usually with the metastasis to the ovary. So pseudomyxoma peritoni is a massive amount of mucus in the peritoneum. So remember, pseudomyxoma peritoni, we have previously studied that it can be caused by the mucinous cyst adenocarcinoma. Yep, mucinous cyst adenocarcinoma of the ovary, like the cells which are the type of ovarian carcinoma which is producing the mucus in excess amount. They can cause the pseudomyxoma peritoni, which can cause the peritoneum to be filled with the mucus, and it can also be due to the mucinous tumor of the appendix, which is usually metastatic to the ovary. Now let's see a Uworld table about the malignant ovarian neoplasms. So histological type, first one is the epithelial type. So serous cyst adenocarcinoma, the most common ovarian cancer, often bilateral, and histology will show up samoma bodies in the case of serous cyst adenocarcinoma. For the mucinous cyst adenocarcinoma, we can find pseudomyxoma peritoni and mucin producing epithelial cells. Now talking about the germ cell malignant tumors, first one is the dysgeminoma. Adolescents, beta HCG will be high, and along with LDH, and histology will show fried egg cells. Again, I would like to highlight that they are coming from the oocytes and they have fried cell histology. Then endodermal sinus or yolk sac tumor, there will be increased alpha fetoprotein. They are aggressive, and shallow duval bodies resemble the glomeruli can also be seen. Okay, so you can see that they have not included the teratoma in the list of germ cell tumors, because we are right now we are talking about the malignant tumors only. Then stroma or sex core tumor, the granulosa cell tumor, which shows the increase in the estrogen, for example the endometrial hyperplasia and and post-menopausal bleeding, they will be increased in Hibin, and histology will show the call-axonal bodies and the coffee bean nuclei. the certainly lady tumors, there will be increased androgen, for example, the hirsutism and the cryptomegaly. Primary ovarian insufficiency. What is meant by that? The pathogenesis of the primary ovarian insufficiency is premature deletion or inadequate development of the ovarian follicles. That is primary ovarian insufficiency. We know that there is ovarian insufficiency in the after the menopause, when the follicles are depleted and there is no more follicle to be released. So resultantly, the female become infertile after the menopause. But if there is primary ovarian insufficiency, in that case at an earlier age, there is premature deletion of the depletion or inadequate development of the ovarian follicles. The clinical features include amenorrhea at age less than 40, increased follicle stimulating hormone, and decreased estrogen. So we know that follicle stimulating hormone, suppose we are talking about menopause. Right now we are not talking about the primary ovarian insufficiency, I am talking about menopause. If a female is having menopause and we have to make the diagnosis, confirmed diagnosis that she has menopause, so we will check the level of FSH. If the FSH level is increased or elevated, so we say that she is having menopause, we confirm the diagnosis. Now if the female is having primary ovarian insufficiency, the pathogenesis is similar but the age is less for the menopause. Like, it is not the age group for the menopause, but it can be it can have similar presentations. So now we are saying that the follicles are not being produced, right? There is a depletion of the ovarian follicles. Now ovarian follicles, the growing ovarian follicle is responsible for the production of estrogen. If estrogen is not being formed, there will be no negative inhibition of the follicle stimulating hormone in the coming from the anterior pituitary, and resultantly we have increased level of FSH in the blood. So whenever there is increased level of follicle stimulating hormone, that is termed to as primary ovarian insufficiency. It is also known as the premature ovarian failure, premature atresia of the ovarian follicle in the women of reproductive age. So premature atresia of the ovarian follicle in the women of reproductive age, most often idiopathic, associated with the chromosomal abnormalities, especially in the females less than 30 years. Need karyotype screening, and patients present with the signs of menopause after puberty but before age 40. And there will be decreased estrogen, increased LH and FSH. That is the characteristic profile of the these enzymes in the menopause. Most common cause of anovulation. Now we'll see that. Pregnancy, polycystic ovarian syndrome, then obesity, hypothalamic pituitary ovarian axis abnormalities, premature ovarian failure, the one we just studied in the previous topic, hyperprolactinemia, thyroid disorders, eating disorders, competitive athletics, that is important one, you must remember this one, competitive athletics, Cushing syndrome, adrenal insufficiency, chromosomal abnormalities, for example the Turner syndrome, functional hypothalamic amenorrhea. So what happens in this one? That is excessive weight loss, strenuous exercise, chronic illness, or eating disorders. So this is a group of the disorder in which we have the functional hypothalamic amenorrhea. Now the person is having these conditions. On top of that, decreased adipose tissue and fat reserves. This will lead to the decreased adipose tissue and fat reserves and decreased leptin production. When there is decreased leptin production, so that will go to the hypothalamus and will decrease the GnRH formation. On top of that, whenever there is decreased GnRH formation, the pituitary will produce decreased LH and FSH, and that will lead to the decreased estrogen production from the ovaries, and amenorrhea and bone loss can be seen because of estrogen depletion. So remember that when a woman is like anorexic and she is losing a lot of weight, or the woman is like very high athletic and she is very conscious of her weight gain and stuff like that, so she will lose the adipose tissue, and on top of that she will lose leptin, and if the leptin is lost, the GnRH production will be decreased. Resultantly, there will be decreased LH and FSH, and estrogen level will be decreased, leading to amenorrhea and the bone loss. Endometrial and myometrial conditions. So endometrial and myometrial conditions. So endometrium is hormonally sensitive. Growth of the endometrium is estrogen driven, that is proliferative phase. The preparation of the endometrium for implantation is progesterone driven, because progesterone is progestation, so that is secretory phase. And shedding occurs after the loss of progesterone, either during the menstrual cycle or after the delivery. Support menstrual phase. Okay, so loss of progesterone by shedding of the endometrium will support the menstrual phase. Progesterone will also so progesterone, because of its high level, is supporting the secretory phase, and because of its low level is supporting the menstrual phase. And for the growth of endometrium, estrogen is responsible for the proliferative phase. Now let's talk about polyps. What are polyps? Hyperplastic protrusion of the endometrium may contain smooth muscle cells as well. May be asymptomatic or present with a painless abnormal uterine bleeding. So polyps can either be painless or may present with the abnormal uterine bleeding, and that abnormal uterine bleeding can present either as that present as dotting. Dotting means that it is between the menstrual period, between the menstruation cycle, like between the one menstruation and the other menstrual bleeding, there is you can say that between the month they will start bleeding, and that bleeding is termed as droughting, and it can rise as a side effect of tamoxifen, which is a high estrogenic effect, which is anti-estrogenic, which has okay. Tamoxifen is a SERM, like specific estrogen receptor modulator. So it has anti-estrogenic effect on the breast, but weak pro-estrogenic effect on the endometrium. That is why I always say that modulator word is a very tricky word, because it is regulating estrogen effects. So if it is the tamoxifen, it has anti-estrogenic effects in the breast cancer. So if a woman is having breast cancer and we are giving her, like suppose a woman who is having breast cancer, she is supposedly postmenopausal, right? And if we are giving her tamoxifen, so tamoxifen has anti-estrogenic effect in the breast, good, but that same tamoxifen has slight pro-estrogenic effect on the endometrium. So in the postmenopausal woman, if there is a pro-estrogenic effect on the endometrium, that will lead to proliferation of the endometrium, and resultantly there may be bleeding. So remember that. And if there is not bleeding, so even worse than that, she can develop endometrial carcinoma because of the tamoxifen consumption. So you must be cautious with that, with these drugs. Then we have adenomyosis. What does the adenomyosis means? Extension of the endometrial tissue into the uterine myometrium. So if there is a picture of that, endometrium in the uterine myometrium. So what happens is that, suppose this is the myometrium, and myometrium contain these spindle like muscle fibers and all that. Okay, this is myometrium, and in front of myometrium we have endometrium like this. It has layers like residua functionalis and the residua basalis and stuff like that. So it has glands like let me make that with different color. So blue is good. So it has glands, right? The endometrial glands. If the endometrial glands, due to some reason, they start moving into the myometrial layer, that particular condition is called as adenomyosis. So if this gland, if this gland is shifted into the endometrium, now this condition is called as adenomyosis. Remember this one. So let's come back. The presentation. Okay. So caused by the hyperplasia of the basal layer of the endometrium. So if the residua basalis is hyperplastic, that can lead to the development of adenomyosis. Presentation: heavy menstrual bleeding, which is due to the increased endometrial surface. Why is there an increased endometrial surface? Because we are talking about residua basalis over here. So suppose this is the residua basalis. This was the total extent of the endometrium. If this becomes hyperplastic and it has started moving in that direction, so now this is the total extent of endometrium. The endometrium has expanded into the myometrium, but expanded. So if it is expanded, so there will be heavy menstrual bleeding, which is due to an increased endometrial surface. Then there will be dysmenorrhea, which is usually from the endometrial tissue growth into the confined myometrial space. So what is dysmenorrhea? Dysmenorrhea is a painful menstruation. So it results from the endometrial tissue growth in the confined myometrial space. Then uniformly enlarged soft globular uterus. It is very important, because I guess later on we will talk about fibroids. Now we are not talking about fibroids. Okay, we are not talking about fibroids. So what is fibroids? Fibroids is basically the leiomyomas, the benign tumors of the ovary. So forget about the adenomyosis for 1 second. So if there is fibroid, so there will be a fibroid over here, maybe over here, maybe something like this. There can be like I don't remember the names. So suppose these are the 3 locations of the fibroids. So if these are the 3 locations of fibroids, so when we will palpate the uterus, we will find a mass like over here and over here and over here. But otherwise the uterus will be uniform. Like the uterus, no, it will not be uniform. The uterus will have uneven growth in different dimensions. That is seen in the case of fibroids. But for the adenomyosis, the whole uterus becomes a globular structure, enlarged, uniformly globular structure, and that can be palpated. So this is the differential point between the adenomyosis and the fibroids. So it will be uniformly large, enlarged, globular and soft uterus. This is due to the hormonal stimulation of the endometrial glandular tissue in the myometrium. Biopsy will show normal appearing endometrial tissue versus the endometrial hyperplasia. In endometrial hyperplasia, we don't find the normal appearing endometrial tissue, but in the case of this one, like the adenomyosis, we find the normal appearing endometrial tissue. The treatment is with the GnRH agonists. Okay, hysterectomy or excision of the organized adenomyoma. If there is an organized adenomyoma, adenomyosis. What is adenomyoma? We are talking about adenomyosis, right? So okay, so if there is organized adenomyoma, let me search that. Adenomyoma. Adenomyoma of the uterus is a circumscribed nodular aggregate of benign endometrial glands surrounded by the endometrial stroma with leiomyomatous smooth muscle bordering of the endometrial. Okay, so I guess if it becomes fair enough, it will be called adenomyoma or stuff like that. So in that case, we have to perform the hysterectomy. Otherwise, GnRH agonist is good enough. Then endometriosis. Now this is a condition which we previously have discussed. So endometriosis, it is a non-neoplastic endometrium-like gland stroma outside the endometrial cavity. Can be found anywhere. Most common site is the ovary and frequently bilateral, then pelvis and peritoneum. Sites of involvement: ovary, and in the ovary it will form chocolate cyst as depicted over here. So this is the chocolate cyst in the ovary. Coming back, why is it chocolate cyst? Because the endometrial tissue is responsive to the hormonal fluctuation, and it may start shedding off because of the menstruation. So if the menstrual bleeding starts within the ovary, that will form a chocolate cyst. Uterine ligaments that can cause pelvic pain. Then Douglas pouch. What is Douglas pouch? Suppose this is the anterior abdominal wall and this is the posterior abdominal wall, and here we have the rectum, and here we have the uterus, and the urinary bladder is over here. Now I need a black color, and we have the black color over here, and let's bring it out. So the peritoneal lining starts from here. It moves on the top of bladder. I don't just know that deep. So it moves on the top of bladder, then it will reflect over the uterus and will make the vesicouteral pouch over here, there, and then it will move posteriorly to the uterus and then will be reflected on the rectum, and this particular pouch is called as the pouch of Douglas. So this pouch of Douglas can also be a potential site for the for this one, like for the endometriosis. So ovary will contain chocolate cyst. In the case of ovarian ligament, we'll have the pelvic pain, and the Douglas pouch, which with the pain with there will be pain with the defecation, that is called as the dyschezia. Then bladder wall, pain with urination. Okay, bowel cirrhosis, abdominal pain and adhesions can develop. Fallopian tube mucosa scarring increases the risk of ectopic tubal pregnancy and infertility. Then implants classically appear yellow, brown or gunpowder nodule. So this gunpowder nodule is a buzzword which they usually give you in the question stems, because it is very hard to find the gunpowder on the biopsy pictures. So they give you in the question stem that there is a gunpowder nodule, stuff like that. Okay, they clinically appear as yellow, brown gunpowder nodules. So endometriosis, there is clinical features include dyspareunia, that is painful in intercourse. Then we have dysmenorrhea, that is painful menstruation, and chronic pelvic pain. The chronic pelvic pain will be cyclic in nature. If it is more than 6 months, can be exacerbated by exercise. That is, so pelvic pain is termed chronic if it is more than 6 months. So most of the conditions are they are termed chronic only when they are they have surpassed the benchmark of more than 6 months. So here we have the chronic pelvic pain, which is pain for more than 6 months, and that pain is cyclic in nature. This may lead to infertility. And dyschezia means painful defecation. So painful intercourse, painful menstruation and painful defecation, depending on the site where we are having the endometrial tissue. Physical examination will show immobile uterus, cervical motion tenderness will be there, and an axial masses can be palpated, and then we'll have the rectovaginal septum, posterior cul-de-sac, rectovaginal septum, posterior cul-de-sac, and ureterosacral ligament nodules. So I guess these are the findings. Okay, then the diagnosis is by direct visualization and surgical biopsy. Treatment is done by the medical, oral contraceptives and NSAIDs. On top of that, surgical resection can also be performed, and there will be a normal size uterus. This is a very important point. In endometriosis, the size of the uterus will be normal. So histopathology shows hemocidin deposits and endometrial glandostroma outside the uterus. In ovary, we have endometrioma. As the endometrial implants shed through the menstrual cycle, they can accumulate old blood which appears chocolate colored, fluid inside an ovarian cyst, that is chocolate cyst. In pelvis and peritoneum, flesh colored nodules, powder burn pattern or adhesive disease can be seen. So here we have the chocolate cyst, and I don't know what that is. I guess these are the hemocidin deposits over there. Pathogenesis, and okay, let's complete that. So pathogenesis may be due to the retrograde flow. Okay, we talked about that. So suppose this is the ovary, and these are the fallopian tubes over there. So the menstruation, instead of going in this direction, they start going in this direction. So that is retrograde flow. metaplastic transformation of the multipotent cells, and transportation of the endometrial tissue in the via lymphatic system. Okay, so these are the three theories of the endometriosis development. Ectopic endometrium responds to the hormonal influences of the menstrual cycle in the same way as the uterine myometrium. That is a very dangerous thing. Okay, bleeding and shedding of the extrauterine endometrium leads to the formation of blood collection in the ectopic location, for example the ovary or the pouch of Douglas or elsewhere. Over time the blood undergoes hemolysis and induces the inflammation. So suppose this is pouch of Douglas and here is the accumulation of blood. That accumulated blood will soon hemolyze, and then it will start inflammation. And when inflammation will start, local inflammation is followed by adhesion formation, which in turn distorts the organ structure and function. Adhesion may interfere with ovulation and fallopian tube function, resulting in the infertility. Implants and adhesions involving the uterosacral ligament can result in the fixed retroverted uterus. Okay, infiltration of the posterior cul-de-sac can result in painful intercourse and tenderness with palpation of the posterior vaginal fornix. So there will be painful intercourse along with and tenderness with the palpation of the posterior vaginal fornix. Shedding of the ectopic tissue causes dysmenorrhea or painful menses. Risk factors are nulliparity, early menarche, and prolonged menses. In contrast, multiparity, extended lactation, late menarche decrease the risk due to less frequent menstrual cycles and opportunity of the endometrial cells to be disseminated outside the uterus. Causes of infertility in endometriosis. The ovary is covered by simple cuboidal cells that divide and proliferate rapidly to repair the ovarian surface defects from the ovulation. Ectopic endometrial tissue in the ovary may impair the fertility by disrupting the folliculogenesis, oocyte release, and oocyte fertilization. Endometriosis involving the fallopian tubes is also common and can impair the fertility by obstructing the tubal transport. It can also result in the ectopic pregnancy, and adhesions can also be seen. Then the treatment is done by the NSAIDs and suppress the endometrial cycle. Continuous OCPs, progestins, GnRH agonists, danazole, and laparoscopic removal can be done. So here you can see the implant in the bladder. Okay, let me zoom it in. So here the implant is present on the bladder. This is endometrioma. I don't know where it is. I guess it is on the ovary. Then implants and adhesions on the uterus, like these are the implants on the uterus, like over the external surface of the uterus. And then we have the uterosacral ligament thickening and implants. So uterosacral ligament thickening, this one is the uterosacral ligament thickening and implant. And then we have the implants on the bowel, like this one is on the colon. So remember this endometriosis, it is very important, and we'll keep it till here, and until next time, Allah Hafiz.